for being here today with us for our third plenary. This morning, our theme focus is innovations in community-led and community-engaged team science. We are very excited to have a great group of speakers to speak with us today. For this session, what we wanted to focus on within that theme was really on violence prevention across the lifespan. And so we're looking across from early childhood through elder abuse prevention and presenting a range of approaches to research that center community members as leaders or as partners. I'd like to thank our conference theme committee that organized today, and it was really a team effort to develop this program. And so you'll be hearing the introductions to the speakers from my co-chair, Dr. Xinzhi Huang, as well as I want to thank our committee members, Dara Blachman-Demner, Brittany Cooper, Nadine Finigan-Carr, Melissa Green-Parker, and Xinzhi Zhang. Thank you all so much, and I will turn it over to Xinzhi.
Good morning, everyone. Sorry, there's a height difference here. I have the pleasure of introducing our three distinguished speakers. Our first speaker will be Dr. David Burns, who is a professor in the Factor Inwentash Faculty of Social Work at the University of Toronto. And Dr. Burns will be presenting on the RISE model, which is a community and evidence-based intervention dedicated to elder mistreatment and elder prevention and abuse. RISE attempts to address an important gap in our system of elder mistreatment response. We'll then have Dr. Renee Boynton-Jarrett, who is an associate professor at the Boston Medical Center and Boston University School of Medicine, who will present her work with Vital Village Networks, which is a trauma-informed approach to promoting child well-being and equity through collaborative partnerships, research, and community leadership development. And last but not least, we will have Lawrence Grandpre, who is the Director of Research for Leaders of a Beautiful Struggle, who will be sharing his work from his partnership with the University of Maryland on the impacts of war on drugs and violence prevention. Specifically, he will be sharing their approach to collaborative research between academics and community researchers that challenges the dominant methodology around how participatory action research is typically conducted in communities. Thank you so much for being here, and I'll turn it over to our speakers.
Thank you so much. I just want to start by thanking Kiara and Xinzhi for your help and your warm introduction. Thank you, as well as to the society at large and the conference planning committee for the invitation. Really happy to be here. It's my first time at this conference, and really happy to be here. So thank you. Okay, so here to talk about the RISE model, which I'll get more into. But before I start, I just want to recognize and thank our key funders for this work, including the Administration for Community Living and the Public Health Agency of Canada. So thank you very much. I also want to recognize and thank our core team here. That includes myself and MT Connolly and Patricia Kimball, Stuart Lewis, and Jeff Rogers. We've been at this for about 5 or 6 years now, and it's been a lot of work, weekly, meetings every week. And I think the nice thing about our team is that we all literally come from different perspectives and disciplines, and I think that's been really helpful. Okay, so I'm aware that maybe the issue of elder mistreatment is perhaps not something you all know about intimately, and so I will go just literally spend one slide here covering some basic background information on it. So when we're talking about the issue of elder mistreatment or elder abuse, I'll use those terms interchangeably. We're talking about stuff that happens in the context of relationships that involve an expectation of trust. Okay, so we're talking about within the context of family, by professionals, friends, neighbors, that kind of thing. We're not talking about kind of random crimes that occur on the street, or perhaps fraud scams that occur, perpetrated by somebody from another continent, kind of thing. Generally speaking, there's 5 subtypes that are accepted sort of forms of elder mistreatment, so financial, emotional, physical, and sexual abuse, as well as neglect by others. And then self-neglect is a very closely related issue as well, that is often dealt with by the same prevention programs. Elder mistreatment, victims of elder mistreatment are significantly more likely to have a shortened lifespan. So over a 9-year period, they're much more likely to have premature mortality. Victimization is associated with poor physical and mental health and traumas, I'm sure you can imagine, social isolation. And then victimization is also associated with increased healthcare costs, such as hospitalization, emergency services usage, and nursing home placement. And very consistently across studies, we find that 1 in 10 older adults experience some form of elder mistreatment each year. And that's across North America. Which is a big, that's a lot. I mean, when you kind of translate that into actual numbers of older adults, 1 in 10 is a huge number. So it's a massive problem, and it certainly is becoming more and more recognized. And then, again, this is all occurring within the kind of the backdrop of an aging population. So this very quickly kind of shows just the changing population kind of demographic structure over time, and hopefully illustrates the point that kind of that bulk of age demographics is moving up towards more of a rectangular shape. And so what does this mean for the issue of elder mistreatment? It means that without effective prevention strategies, we can kind of assume that the incidence and prevalence rates will remain constant, and the absolute scope or the actual numbers of cases are going to increase in proportion with the growth of the older adult population. So there really is a pressing need for elder mistreatment prevention and response programs. Now, one of the things that every year, so there's this pressing need for prevention and response programs. Unfortunately, historically, we have not had that. So basically every year there's a new systematic review that comes out. And more recently in 2020, this was a review of reviews, so we're kind of getting into the meta reviews that basically come up with the same finding over and over, that there's limited evidence-based elder mistreatment or elder abuse interventions. And so this is a huge gap in our field and something that needs to be addressed. And in the last, I would say, few years, there are really exciting and promising developments. Okay, so why did we develop RISE? So again, you may not be aware that here in the US, every state has an adult protective service system, okay? That is the main agency responsible here for receiving reports of alleged mistreatment and addressing this issue. Okay, they generally have 3 phases of their intervention process. There's an intake phase, an investigation phase, and then a sort of a case substantiation or determination phase. In 2020, there was about 1.3 million reports to APS. Of those, about 770,000 investigations. And then of those, 260,000 substantiated cases. Again, we also know that only 15% of elder mistreatment victims who live in the community ever come into contact with formal support services. So this represents a minority of victims out there. On average, the investigation phase takes about 55 days, and the total kind of case open time for an APS case is about 67 days, okay? So you can see that I'm kind of speaking in very broad, general terms. There's about 12 days there for intervention, right, between the time that the investigation closes and the case closes. So that really only leaves on kind of opportunity for very brief intervention, making referrals, and hopefully addressing like immediate safety needs. But what is missing from our system is an actual intervention phase. One that is conceptually driven, but is evidence-based, but it is really dedicated to kind of the prevention and response of these, re-victimization and kind of addressing underlying needs and risk factors. And so that's where RISE comes in. That's why we developed RISE, and where our partnership with APS, that's sort of the complementary partnership that we've created with APS. We also found, again, kind of in terms of why did we create RISE, there tends to be kind of like a siloed system of services out there, one for victims and one for perpetrators. But as I'll go on here, really, there's not much in the way of working with them together at the level of their relationship with us, which is actually very, very important in this particular issue. So that's why we developed RISE. As I'll go through here, it's now one of the first evidence-informed programs worldwide dedicated to the prevention and response of elder mistreatment. And I'm going to go through some evidence related to feasibility, acceptability, and improvement on case outcomes. And we're now implementing in multiple locations. Okay, so RISE was developed based on prior research, theory, a lot of consultations with older adults themselves and key stakeholders in the field. We've intentionally integrated modalities or core components into the intervention that have received evidence in other domains of family violence or promising results with victims of elder mistreatment, and of course, pilot testing. Sorry, this is sometimes, okay, there we go. And what we found is that when we conducted interviews with elder mistreatment survivors, we asked them a lot of questions around, like, what are the barriers to engagement? Like, why is it that it's so difficult to come forward and engage with formal support services? As I said before, that's arguably the most difficult aspect of this work, is actually engaging older adults to work with you. And what are the most distressing aspects of victimization, and so that we can sort of understand more how to develop this intervention. And I'm not going to go through all these, but basically, there's a lot of quite, as you could imagine, intense, psycho-emotional, and social needs that these older adults are facing. And what we found is that an elder mistreatment intervention, it has to go beyond kind of arm's length case management, and it has to move sort of more towards some kind of intervention model that has the capacity to deal with those psycho-emotional issues. You can see here that a lot of the times their concern is for the perpetrator or others involved in the case. You have to remember, with elder mistreatment, often the perpetrator is an adult child or a grandchild or a spouse. But it's often a situation where they're very, very reluctant to engage with formal support services because they're worried that maybe their child will become implicated in the legal justice system or something. And so it's a very difficult situation that they're torn in multiple directions. So the capacity to work with others in the case and when possible take a restorative stance. Our model is informed by an ecological systems perspective, just acknowledging that for the most part, interventions out there only work with victims of elder mistreatment, but our theory suggests that ideally an intervention ought to be able to work with both the victim and the harmer, with them together when appropriate, and then also address risk factors at these higher levels of ecological influence to address the full scope of risk. This is a very, very, like every case is very different. We've got these different kind of subtypes. Apologies for the drawing. It kind of looks like a 5-year-old did this, but basically it's supposed to kind of indicate that each case has a very different trajectory of change. Some cases go sideways, some cases go backwards. I mean, it's really, they all have different needs, and so you really have to take a client-centered perspective. Unfortunately, you can't take a highly kind of standardized, manualized approach to these cases. And then often based on older adults have the right to self-determination. So they actually get to choose what does my resolution look like? And sometimes that is a resolution that includes perhaps continuing to live with their harmer. Maybe their harmer is their caregiver. Maybe their harmer is a dependent adult child who is still living in their home. So you're also coming at this from somewhat of a harm reduction model as well. But every kind of target, kind of best solution is often different across cases. So that also complicates things. And then we're coming at this from a highly relational perspective. I've mentioned the importance of the relationship between the client and we call them advocates or caseworkers, but basically trying to overcome that engagement challenge. So we put a lot of emphasis on relationship building and trust building between our advocates and our clients. Coming at this from a perspective of cultural humility and curiosity and openness as it relates to working cross-culturally. And really, being quite creative in our engagement. again, the relationship between the victim and the harmer, often they're looking to repair that relationship. They're not looking to kind of sever it. Because severing that relationship often would mean, removing somebody from the home or changing locations, or, it's just often not something that an older adult wants. And then the importance of the relationships in their community. One of the kind of strongest risk factors for elder mistreatment is social support. Protective factors, I should say. So a big part of this model is trying to bolster that social support. Okay, and then we work with older adults who are aged 60 years or older, who are either experiencing mistreatment or are at risk for mistreatment. So APS will often refer us cases where it doesn't necessarily meet the threshold for their substantiation, but there's a lot of indications there, and without support, you could see that things could escalate and bubble up. So, so we do focus on both prevention and response. And here are the core components of our model. So we use motivational interviewing with the older adult and the harmer individually, which some of you may be familiar with. And basically, it's a strategy that's used with populations who are often reluctant to engage in change work. And so this sort of tries to open people up to the possibility of change. We use restorative approaches when the older adult wishes and when it's appropriate to work with them as a relationship, which holds the harmer accountable while also repairing harm in the relationship. We use a technique called teaming to bolster social support and social connection, which is borrowed from the child welfare system. And basically what that is that you create a team of informal and formal supporters around them, who take a collective responsibility or sort of shared responsibility to prevent this from happening again. And that team, again, ideally remains intact even after we close the case so that there's more kind of longer term sustainable outcomes. And then supported decision-making in cases involving older adults who lack some level of capacity. This was published in the Gerontologist, this model, which you can sort of feel free to take a look at. But again, it kind of represents the different levels of ecological influence and that we try to address in this model. Okay, so I'll talk a little bit about the findings that we, in Maine, the state of Maine. So in 2019, we did pilot work in 2 randomly selected counties, 1 urban, 1 rural. And then based on that data, it was expanded throughout the state. And then just last year, we were really excited to learn that it's been incorporated into their permanent budget, which was really exciting for us. And so to date, we've worked with about 800 cases throughout the state of Maine. We've got 2 supervisors and 8 advocates across the state. Average caseloads of about 20 to 25. All of the referrals, if you can recall that slide with the APS RISE partnership, all of the referrals come from APS. Mostly working with women, average age of 75 in both rural and urban settings. And then some of the findings from our main work. So, I mentioned that we really place a lot of emphasis on engagement, and what we find is that when we do get referrals from APS, about 94% of them accept our services, and then among those who do accept our services, about, again, 95% voluntarily remain retained. When we ask active clients about their kind of satisfaction with our program, about 75% say that it meets most or almost all their needs, and about 80% say that they would come back if something else came up. Again, that kind of client-centered approach, about 80% of clients describe kind of a collaborative relationship with their advocates and believe that advocates respect their choices much or all of the time. And then this is kind of, you think of the stages of change model. Often this is really difficult work for victims to engage in, and they might start out at you got these stages from pre-contemplation up to action and maintenance. And what we find is that the majority of our cases do progress forward in their stages of change, which is great. I mean, you don't always kind of see somebody go through the entire kind of scope of change, but it's about sometimes incremental movements forward. And then what we found is that our sort of big finding at the moment is just our impact on recidivism. So cases that are exposed to the APS plus RISE intervention model are significantly less likely to come back into the system than cases that only receive APS. And that accounts for the fact that cases referred to RISE are much more complex and severe. So they do often, and it makes sense. They refer us the cases that have a lot of need. And this finding holds through the different kind of subtypes of self-neglect and mistreatment. And even when you look at kind of combinations of different types of mistreatment, it holds. So that was really exciting for us. And sort of when you account for the number of previously substantiated allegations, so kind of again kind of a proxy indicator of kind of complexity or severity. In both groups, as the number of previous substantiated allegations goes up, so does the probability and likelihood of recidivism. But we found that the group receiving RISE was significantly lower. And then we conducted a series of qualitative interviews with the APS practitioners with whom we partnered and made referrals to us, and they generally felt that it was a very complementary relationship and kind of service arrangement. It allowed them to focus on sort of immediate safety while we could kind of take on more kind of address more longer term needs. They appreciated the flexibility to work with sub-threshold cases because, interestingly, and we weren't anticipating this, but a lot of them actually said that it helped with their own psycho-emotional well-being because, often they knew they were closing cases and it just didn't feel necessarily right, but they had somewhere to hand it off, and that was very helpful for them as well. So here are the different places where we are currently. So I've mentioned Maine. We're in the planning phases in Montana. I currently run a program in Ontario where I work out of our faculty, which is a bit crazy. I'm not going to lie, to take that on. But and then we've just started in New Hampshire, and then we're also in planning with the Pittsburgh VA, so implementing RISE into the VA health system. And we were very excited. Just recently, a couple months ago, the Administration for Community Living announced a funding opportunity specific to RISE to replicate and scale and evaluate RISE in three new states. Very briefly, in Ontario, what we're doing there is we're partnering again. We don't have adult protective services in Canada, throughout most of Canada, I should say. But we're partnering with kind of the organization that has a centralized helpline, essentially, where family members, victims, service providers can call in if they have concerns about an older adult. They do an initial consultation and screening, and then refer eligible cases to RISE, where we do that kind of direct response. And okay, thank you. Have you been holding that up for 3 minutes, though? Okay, good. So yeah, and then so we're now moving on towards more prospective. This is being carried out in the context of a randomized control trial. Again, trying to strengthen, I guess, the rigor of the evaluation. And to date, we've worked with about 50 cases. It's only a few months old, and in both rural and urban settings. I mean, I hesitated to kind of put this in because it's only based on 24 cases that have pre-post data collection, but we have found that there is a significant difference in perceived stress and social self-efficacy between those who receive RISE versus those that don't. We have a website if you'd like to check it out, risecollaborative.org. The social media, I think I'm kind of in charge of it, and I'm not exactly probably the person who should be, but you can certainly go check it out. We actually haven't posted anything on LinkedIn there. We have an account. We posted a few things on Twitter X, and yeah, if anyone's interested in kind of, we've published several articles on research and evaluation of RISE. And I will leave it there. Thank you.
So this is the 8 a.m. crew. So you all are definitely my tribe in terms of, oops, did I do the wrong thing? In terms of the people who get up bright and early in the morning to think a little bit about how we prevent violence and transform our society. So happy to be here with you all and really honored to be on this panel today. So I'm going to shake things up a little bit and talk about the ways in which we think about community-led innovation and participatory research to help advance birth justice. And my explicit assumption is that our profound inequities by race and ethnicity and by socioeconomic status around birth outcomes and maternal morbidity and mortality is driven by structural and social violence. So, oops, I might be using the correct, or do I point? Friend, maybe our battery has died. Oh, okay, let's go for it. All right, so we're gonna, we'll talk a little bit about the background. So if you think about maternal mortality ratios in selected countries between 2018, you can see the United States in the orange bar has an extremely much higher rate of deaths per 100,000 live births. And this is a chart comparing the United States to peer countries around the world, right? So there are a number of peer countries selected here. So I want to ask a question about the framing of that data that I just shared with you. What context is missing? And what framing did I select for introducing maternal mortality and morbidity around the world by that framing of comparing the United States to peer countries, right? So there are several decisions made about how that data was shared that are driven by a set of hypotheses. First, the United States is being compared to countries that have relatively similar GDP and income, right? So we've selected a number of wealthy nations around the country and ignored the much broader context. So if we actually look globally at maternal morbidity and mortality, you can see the dark blue areas in sub-Saharan Africa, Afghanistan, and other places actually experience an extremely higher rate of maternal morbidity and mortality. And often these are called least developed countries. So we're often making comparisons among quote unquote more developed countries and less developed countries. And that is related to a series of assumptions or hypotheses we might have around what are some of the drivers of reduced maternal morbidity and mortality. So we know over time, over the past few decades, globally, maternal morbidity and mortality has been declining across all countries. But there are several choices that are made in how we frame and share data. And what we know is that the context matters. So presenting data within a particular context really designs how we begin to think about that data and act on it. And excluding some elements of context really frame ways we think about problem solving. So if we believe better health is associated with wealth, income, and investments in the healthcare industry, we may present data around how to address maternal mortality in a different way than if we believe there are other drivers. There are, like if we narrow into the United States context, there are a lot of historical legacies to think about here. One, our history of reproductive control, oppression, and the denial of humanity and reproductive rights that were associated with enslavement, immigration, and migration. We have a very long history in our country of enslaved people being viewed and valued in terms of their ability to reproduce. As well as physicians and scientists who utilized enslaved people to experiment and to test out medical techniques. So Dr. Sims might be one example, often known as the father of gynecology, who did a lot of experimentation and treatment without anesthesia, consent, or pain medication or management on enslaved women. And so these narratives become very important. You can also look at another set of narratives around midwives who were discredited by the medical institution in our country systematically in order to elevate a particular type of evidence, a particular set of healthcare approaches that we know, when looking kind of globally, actually are not panning out as factors that actually lead to greater degrees of health equity. So how we tell these stories and how we frame our data really direct our attention to a certain set of solutions and cause us to exclude and/or ignore another set of solutions. So for example, if we look at the maternal care workforce, we can see in the United States, we actually have a very, very low workforce of midwives per 100,000 live births in comparison to other quote unquote peer nations that have actually a much more extensive workforce of midwives. That is not unrelated to our historical narratives, legacies, and stories. When we look at weeks of paid maternal leave, we can see in the United States, again, we see this trend carrying forward. So there's a lot more to the story around maternal and perinatal health and well-being that looks at social policies, social structures that impact the lives of women and children and inform our healthcare system. As you can see, we are really high on our spending, the percentage of our spending in GDP. And again, in comparison to the peer countries, we're spending way beyond with worse outcomes. But when we look at our social care spending, which are the blue bars, we spend the least on social care, where our quote unquote peer nations invest the most, where our largest investment is really around healthcare. So when we start to integrate different forms of data, we start to develop and see a different picture and better understand non-random patterns. So really, when we're thinking about how we would address forms of structural violence in our society, like structural racism, which disproportionately impacts communities and children of color, we really have to begin to think about different stories, but also engage different people in terms of defining and shaping the metrics, the data, the research processes, as well as the solution. So when we think about structural racism in this context, there's different data we can begin to look at. African-born Black women in the United States have heavier babies than US-born Black women. We can begin to look at cumulative life experiences of interpersonal racism and discrimination and their impact on preterm births. We can begin to look at markers of cumulative stress, indicators of chronic weathering over the life course, and impact on preterm birth rates and birth outcomes. And we can see when we ask that experiences of discrimination, traumatic birth experiences, experiences of racism when seeking healthcare are higher among Black women and also associated with markers for poor cellular immunity, higher risk for infections, and intrapartum, postpartum complications. When we look at documented policies, so historical policies that systematically disadvantaged a group based on race, ethnicity, such as redlining, so that's one of the policies we have on the books where we can look, we can see that there's a difference between historical redlining and life expectancy and preterm birth risk today. So historical redlining in communities today, we still see a contributing risk. So none of this is new information for you all, right? So race, we know, is not a biological category. It is a social category that has staggering biological consequences and the impact because of how social inequity impacts people's health. We can dive into our medical processes, thinking about diagnostic algorithms, who gets treated for anemia, who is recommended for a vaginal birth after C-section, understanding that in these algorithms, race has been included as if it is a biological category. And there are movements to address that. We can also look at implicit bias and physician training. Many medical students, even when interviewed now, may believe that their false beliefs around pain tolerance, pain management by race ethnicity that we see bearing out in terms of how people get treatment, time to treatment, and extent of treatment. And then when we think about how we think about a resilience framework in our healthcare system, we often center community engagement. But what we mean by community engagement often is very variable. So I'd like to talk a little bit about our work with Vital Village Networks and our process for really thinking about how we are very intentional around community engagement, community partnerships, and often that begins with really thinking differently. So we're organized as a network of residents and institutions and agencies that are focused on maximizing child, family, and community well-being. And in this work, we use a trauma-informed lens to really think about how ways in which we have organized society and the impact of early life adversities on life course health outcomes impact your health trajectory. And we're guided by several principles. So really centering dignity and equity to create a space of belonging, learning from those closest to the challenge, engaging by designing with and not for users, and those are the foundations of social transformation. So our work is often thinking about developing leaders as well as connecting institutions. So we use a collaborative approach to co-create solutions. We use cross-sector engagement strategies, and we develop dashboards and tools to share ownership for data and benchmarks for child well-being. So I'll talk a little bit more about that. So often when we think about community engagement, we think about how we gain the trust of community members. So I want to start from a different place. I think we really have to think about how we build institutional capacity to be trustworthy. So institutional trust is the extent to which individuals accept or perceive institutions are benevolent, competent, reliable, and responsible towards citizens. Now, this is predictive of interpersonal trust, but often we're focused on how do we get the community to trust us instead of what do we need to do to demonstrate institutional trust. So institutional trust drives feelings of security and trusting beliefs. But what comes before that is trustworthy practices. So this is something we can all do in our healthcare institutions. Trustworthiness is a requisite condition to foster trust. It's frequently overlooked, but in the absence of trustworthiness, distrust is the only rational belief. So we're asking people to deny a rational set of thinking and just kind of trust that we will demonstrate trustworthiness in the future. But we could actually lead with that. So what are things that institutions can do? You can acknowledge historic untrustworthiness and harm, neglect institutional racism, and failure to address structural violence. You can situate distrust in historical as well as contemporary injustices. And then you can embrace a social justice imperative where there are policies in place to center those who have been minoritized and marginalized and harmed. So think about it for a moment, just to push us a step further. Can institutions with histories of pervasive, inequitable treatment demonstrate trustworthiness outside of some significant transformation of leadership, collaboration, or partnership? So what I mean, if the players on the chessboard do not change at all, there is no change in the players on the chessboard, is that really a demonstration of trustworthy practices. You'd fundamentally, so we saw this very easily with the COVID-19 pandemic. Many institutions started setting up vaccine clinics, and they were much more successful if you actually collaborated with the faith-based community and trusted, experienced community leaders, if you collaborated with nonprofits, if community members actually were involved in designing and being at the front lines within those clinics. So we have very, very accessible and easy examples of this, but there has to be some transformation beyond language or statements. There actually has to be some transformation of who's in leadership or how we partner. So collaborating and partnering with trusted sources within the community, trusted institutions within the community, setting yourself up to welcome diverse forms of wisdom, intergenerational, cross-cultural, and not just welcome from a hearing community voice perspective, but really welcome in terms of we will get behind some ideas that are not evidence-based, that are, based on indigenous, culturally rooted knowledge. And there's a space for that. That might not be the space of all of the policies, but there is a space for that to begin. And then investing in a healthcare and public health practice that is community-centered and driven. So often when we're talking about community partnership, I like to use the example that we're all familiar with. We were all in elementary school. We were all in gym class. We all got picked for the dodgeball team. And so when you're picking partners for your team, if you don't know if they can duck, throw, run fast, you are not going to pick them. So you cannot partner with a community based on their challenges alone. If you know nothing of strengths of the community you are hoping to partner with, that will not be an equitable partnership from the beginning. So it is just as simple as that. The commitment really is that we actually need each other to reduce health inequities and to build health justice. And if we don't actually need to work together, we're really not setting up a fundamentally equitable partnership that requires the wisdom and solution and ideas of community members to begin with. So a lot of this is getting into power and social forces. I mean, all of us in the room, we can all raise our hands. We're doing this work because we care and we want to make a difference, but we also believe that we have something to add. And that becomes a power dynamic, right? In terms of who is in the helping role, who is in the solutions role. So that's something to be really, really intentional and cognizant about. How can we distribute capital and resources? How can we expand leadership? Where are there spaces for us to take a step back? It is wonderful to have a service orientation and mentality, but where might that get in the way? Really in terms of our ideas about what works and what doesn't work, or what's the right way to do things. So really expanding opportunities to share power and being sensitive to the fact that for many communities and individuals you may be working with, they've heard this narrative before. We want to partner, we want to work together, and then the funding dries up and everything disappears overnight. So you really have to have a trauma-informed lens of thinking about the history of academic institution, research institution, large anchor healthcare system partnerships with communities in the past, and think about how this could be different. There's really no, and often what's not really talked about when we think about power sharing, we might think about diversity in terms of race, ethnicity, or in terms of socioeconomic status, or even educational background. But we have to really begin to expand our thoughts around power sharing. Are those with cognitive differences, learning differences, not worthy of being in positions to share power around decision making? So we really have to push our thinking. So I'll give some examples of how we do this in our work, beginning with shared data systems and participatory research. So I won't go into this slide too much, it's very busy, but as you know, a participatory process of systematic research inquiry really begins with engagement. But we really have to think about how we decolonize this model. What forms of knowledge do we not value? because some things are not heard as wisdom and not heard as ideas because we simply don't value that. So if I don't believe the moon is purple, I'm not going to do a research study for the next 10 years studying why the moon is purple and how it became purple. So we really have to expect and understand that our scientific inquiry is not fully objective. It is informed by our ways we think the world works. So other people think the world works differently. So you really have to have a much greater openness to welcoming different ideas, or a very clear accountability structure that has some checks and balances about which ideas would get vetoed simply because we don't think they're good ideas. Who owns the data and the stories collected, for how long and under what conditions? So often we're so excited about engagement and sharing information. In the space of maternal mortality, we can hear testimony after testimony of traumatic loss and experience. But where is there the space to share the solutions? How interested are we in hearing from the very same individuals about what they wish would have happened differently, or how they think the healthcare system could have been set up differently? So it's a deep imbalance. We kind of are, consuming trauma narratives publicly with very little interest in consuming solution narratives, often because we don't believe those are the right solutions. And then what does accountability look like? What does it mean to not just tell the story and collect the data, but what are we accountable for doing based on what we've heard? What actions are we accountable for? So these are all really important questions when we're even thinking about participatory research. And then a lot of our work is really on making public, community-designed data dashboards publicly available and open and shared. So really finding abundance. Who are the individuals that have not been allowed to design a data visualization about their neighborhood, to talk about the strengths as well as the challenges, framing them in very different ways? How do we share and collaborate around data? And particularly, how do we make technology accessible so that actual ownership of the data is not going to require a Salesforce license that's very expensive, or red cap privileges or things of that nature, but how do we create systems that are secure and ethical but can be completely owned and operated indefinitely by members of the community? And this really should be funded through federal and state dollars. So this is an example of a map that community members requested around needle safety. There are needles that were being found in parks, playgrounds, and school playlots, and they wanted a data tool that talked about the increase in this, as well as the absence of simple public health programs that would actually lead to those being deposited more safely and help protect children. So this is the way of following the community's request to create maps that they can use with their legislators and tell new data stories. So really thinking about systems designed for and by caregivers and families. A couple examples of how we do this. We really think about how to collate and share data, but make sure that all of that is fully accessible to members of the community. We also think about how do you build capacity. So we run a series of free data storytelling workshops where stakeholders can really share best practices with each other, collaborate, but also learn skills and tools for GIS modeling, for shared participatory mapping, and for creating visualizations that tell the story through a different perspective. And then we host community data work groups where collections of people come together to work around issues. We might be working on an issue that feels very similar, housing insecurity or housing justice, but what ends up happening is the questions are fundamentally different. So we've been working on housing affordability, and the primary question the community members wanted to ask was, who gets to define what's affordable housing? Because the definitions that are being used to drive the distribution of resources actually don't match our definitions of what affordable, safe, and secure housing is. And then we just have to think about how we transform the community care workforce. So really thinking about the abundance of people in the community that can actually offer therapeutic spaces for healing and health promotion. It may not be therapy, it may not be direct health care or service, but imagine a world where we actually welcome community members who we are often putting in the position of patient or recipient of service as an equal partner in promoting health and well-being, and really viewing everyone as having the potential to be a healer. So we've done a lot of this work when thinking about breastfeeding and lactation, and many of these civic leaders had poor or traumatic experiences themselves and know they have something different to be offered. It's just a matter of setting up a system and a structure to break through some of the glass ceilings around accreditation, training, and access to resources and partnerships. So really designing with and not for, honoring community wisdom and experience, and building equitable leadership, governance, and decision-making processes. In that model I was just sharing, this is a very sustainable model because people who are trained and volunteer in the model become mentors of the future group of people. So it's a very lean, cost-effective model. However, it requires power sharing and redistribution of who can be the trainers, who can be the faculty, who can be the mentors to members of the community that may have a different educational background, may not have English as a primary language, but bring a wealth of other experiences and culturally rooted knowledge that's important and valuable. So really thinking about not how we build leadership in the community, but how we acknowledge and uplift existing leadership in the community. And often that's a change in us as opposed to a change. So sometimes in community partnerships, people want people to show up differently. They don't like how they show up. They don't like how they participate. It feels uncomfortable. Often, doing something different is going to require some degree of stretch and discomfort. So it's pretty reassuring to me whenever I'm feeling uncomfortable. I know that we're walking the walk. Really thinking about pathways for new leadership styles, collaborative and collective forms of leadership that are not hierarchical, and really thinking about constantly who's being marginalized by our process and how can we center those who are being actively marginalized within our process. So leading with dignity. So we're always striving to reduce health inequities, but I think when we put dignity into the center, it really elevates our striving, because we all understand from our own experience what it feels like to be treated with dignity as a human being, and how crucial, and what it feels like to experience an indignity. It's actually a much higher bar we begin to set for what health equity looks like if we think about dignity-centered and affirming care, dignity-centered partnerships, and dignity-centered research. So really thinking about that would mean, when thinking about the ethics of any data that's collected or shared with community members, how is dignity at the center, and how does that person's agency remain active over time? It means there's probably not just a one point in time consent to use data indefinitely forever. It means there's probably a design of a recurring conversation around consent for information to be shared in an ongoing way, and the conditions for that sharing. So bringing it back to kind of where we started around birth and reproductive justice, really thinking about our power systems, thinking about intersecting levels of oppression, sometimes around education, knowledge, academic training, centering those who have been most marginalized or are currently being marginalized in the process we're using, and joining together across issues and identities. So this really leads us to a transformative community capacity model. Really, just to review what I've already shared, addressing historical injustices, centering the agency of parents, children, and families, creating processes for ongoing and iterative improvement, and bringing in a lifespan perspective and strengths-based models. And for time, I'm going to just skip this last slide, but we can talk about it more in the Q&A. But, you know, I'm always inspired by this quote: if you've come here to help me, you are wasting your time. But if you've come because your liberation is bound up with mine, then let us work together. And I think that really is the essence of centering dignity, in that actually we experience a greater fulfillment of our own humanity when we recognize the humanity of others. So that really has to be centered in research, and that has to be centered in partnership. Very different than some of the other ways we think about it. So I just want to acknowledge our research team and all the community partners that we've been on this journey with. And thank you all. You can reach out to us anytime.
Good morning. My name is Grandpre. I'm Director of Research for Leaders of a Beautiful Struggle. We're a grassroots think tank based in Baltimore City. I feel like my remarks are going to mirror some things that have been said, but probably be a little bit different. I don't have any slides. I'm just going to talk about the research we do, and specifically the way in which the research we do may challenge some scholarly assumptions and research assumptions that may be embedded in dominant systems of research. So LBS, Leaders of a Beautiful Struggle, we come out of the world of policy debate. And policy debate is a two-person form of debate. It's one topic for the whole country. So you have these big debate tournaments, like almost like an NCAA basketball tournament. And it came from an investment from OSF in inner city schools in the 90s, creating these urban debate leagues. So this is an expensive activity. You have to travel, pay a coach, do a lot of research. It's very research-based, and it's actually created by West Point. Before policy debate tournaments, it was like the great debaters. You'd come and have a big public debate, be it an invitation or a challenge. But with West Point coming in, there was this debate tournament style. It was specifically designed to create Cold War think tank style people. So even the style of debate was impacted by this. There was an increased rate of speech. Everything began to focus on worst case scenario planning. Nuclear war became a huge focus of the activity. Like Elizabeth Warren did the style debate. It was a policy wonk style debate, and you were bringing folks who were experiencing poverty, racism, adverse childhood experiences, and this community was actively hostile to young Black students exploring the issues that impacted their lives in debate rounds. You would literally say the government should invest in solving racism, and they will say that crashes the economy, leads to nuclear war. Nuclear war outweighs racism, sorry you lose, right? So it was important for young Black students to not just do debate, but to challenge the systems of evaluation, of research and debate. So our organization comes out of an intellectual and scholarly intervention by Black elders in the debate space, particularly from the University of Louisville, to take these young urban debate league kids who, the reality was these were white-run nonprofits. They didn't have a vision of these kids even being capable of being policy debate champions. This activity was formed as a literacy and attendance program, and honestly, a conflict prevention program. Hopefully, these two-person debate teams will somehow be conflict prevention. But of the first 10 Black college debaters to debate for a national championship, I think 5 of them are from Baltimore. We just had 2 young women from Baltimore win the high school debate national championship last week, and actually were 3rd at another championship. So I bring that up to say that part of what we did was challenge the assumptive logic of the research in the community. So the assumption is that you need to have this abstract, objective, quote unquote, pragmatic analysis, and University of Louisville brought in what they call a 3-tier methodology. So you need to evaluate truth claims and research by 3 criteria: personal experience, traditional academics, and organic intellectuals. So organic intellectuals coming from Antonio Gramsci, folks who have lived experience and are putting that into writing and research. So my talk is really based upon this analysis coming from LBS, our work we've done with police accountability, getting grassroots investments in Black organizations, but also doing work on researching a variety of issues, because the objections they brought to us in debate were actually many of the objections they bring to academics like you who want to bring in alternative perspectives. It's that we need to have research, not me-search. Personal experience becomes too subjective, and we need to have objectivity. And we can't make things too quote unquote political. So our retort in debate and our work as researchers and political advocates is that not just lowercase p, capital P, all research is political. And if you're not having an intentional relationship to those politics, you're allowing those politics to potentially dominate your research in ways that you aren't cognizant of. And we do not focus on personal experience because we fetishize individuals and we fetishize oppression. People have specific experiences and specific forms of expertise that, when excluded from research and policy, end up replicating problematic and end up creating bad research products objectively. So that's the context I want to explain the research we did that was talked about in the intro. So we are not a non-for-profit. We made an intentional decision to not be a non-for-profit. We are LLC that engages in political advocacy, and we do research. So we support traditional academics when they do research, helping them frame their research, helping give them qualitative input. So Open Society Foundation wanted to do a research product on the harms of drug criminalization in Maryland, because they wanted this product to support a push opioid decriminalization in Maryland because of the overdose crisis. So they came to some of the University of Maryland School of Social Work. They came to us. And the issue from our perspective with traditional participatory action research is that the community is oftentimes a garnish in terms of the actual research product. So our experience has been, again, this is being used in a city like Baltimore. Lots of researchers come to our community. An academic has a perspective. They have a thesis, a hypothesis. They produce research questions and methodology. The community then does the interviewing, gives the data back to the traditional researcher. Traditional researcher writes the product, gives the TED Talk, gets the grants, and the community is thanked in the research project somewhere. And they get a gift card, like a Visa gift card, something like that. So I think it wasn't the intention of OSF, but they had a particular agenda. They wanted to pass a bill. And all they knew about passing a bill was that we need to create a product that supports how we think policy change happens. So OSF was honestly very hands-off, but the one thing they did say was, what's the number? And I was saying, what's the number? And for them, the number for this argument is, how much money do police, quote unquote, waste policing low-level drug crime? Because then we can convince moderates who are fiscal moderates that we should decriminalize drugs to save money. That was their vision of policy change. So we have a fundamentally different vision of policy change, so that produced a fundamentally different research methodology. So I basically told my research partners, who were traditional researchers, look, I'm pretty busy. I'm not going to do these interviews. What I'm going to do is I'm going to write the interview guide. I'm going to give you the people to interview. You're going to do the interviews. I'm going to help you interpret the data, and I'm going to write the intro and outro. And that's going to provide this theory that frames the data and puts it in context. That's what we did. So we have this product out. It's the community impacts of drug criminalization in Maryland. And because we had a diversity of people interviewed, not just addiction people, people who are working with youth, people who are elders in community, people who don't directly do addiction services, but have an experience of addiction living in the community. They've experienced drug criminalization in terms of what happened to community after drug arrests came. And their perspective on what they found was very different than the traditional perspective. So some of the things they found that inverted perspectives, traditional perspectives on how this argument typically goes. So one thing people assumed was that the legalization of cannabis would prove the validity of legalizing opioids. So the argument was legalize cannabis, sky didn't fall, community's cool with it, that's gonna open up the space for legalizing opioids. What we found was largely the opposite. Community experienced the legalization of cannabis through a long history of drug policy being a tool from their perspective of exploitation in the Black community, stemming largely from the feeling of the 80s of crack being allowed to fester in the Black community and or being pushed onto the Black community to disrupt political movements, to increase arrests in the Black community. The feeling was that they were seeing more people using high-strength cannabis, more cannabis shops opening in their community, and they were saying, well, this is good for the people selling the cannabis legally, but they just view us as a source of profit. They want us to buy cannabis from them as opposed to the weed person we typically buy it from. And even though there was no market component, they didn't want to legalize and sell opioids legally. The community was processing opioid legalization from that heuristic. They're just doing this because somehow they make money off of it. And that was perceived through the social services they wanted to bring to address addiction. So as opposed to exciting community with the perspective of more quote-unquote investment in social services, the community framed that investment to a feeling of exploitation, and that this was only really designed to benefit powerful white folks, and or they're doing it now because white folks are dying and didn't care about all the ways we died in the past. So kind of along those lines, doing the qualitative research, we found that the assumption, again, was that increased investment would be a tool that would bring community to support decriminalization. The reality is that community experienced this investment through what some people would call a nonprofit industrial complex, another frame of exploitation. So I did want to read one quote from one of the persons we interviewed anonymously from this paper. And this is talking about their experience of the addiction system that theoretically will be invested in with decriminalization. They say, quote, "There used to be a monthly meeting of residential providers to talk about the changes in the field of residential housing and network with each other. Horrible abuses were happening there. I've seen firsthand horrible abuses inpatient and outpatient, client trading, forgery of paperwork, inventing clients who didn't actually exist, creating whole cases from the ground up, people who didn't exist so we can bill for them, fraudulent audits, where you can get teams of people to come in and create fake notes and fake clients to justify billing. The assumption is that's just how it goes. The programs are big now, built their foundations of institutions on fraudulence, navigating fraudulence, and learning how to navigate fraudulence. These are good-hearted people, but the truth is, this is driven by money. How much time is going to take for someone to move through our treatment protocols? So that way we can prove to the state that we're meeting our goals, and that way we can prove that we deserve more money, or the university. How much money do we have to do things to take clients into the community, or do things socially required? The drive, of course, is how we're going to keep our jobs. How do we keep the money coming in? So from that perspective, that really flips so much of the assumptive logic of, I think, so much of our research. We're so busy trying to prove justification for investments from the government research grants, so focused on getting the money, not focused on how people experience the programs and how people experience the power dynamics behind how the funding flows. So if folks perceive the institutions dominating as creating exploitative arrangements, they're experiencing not just policing and incarceration, but the so-called social service system as another vector of violence and social control. Again, so the goal of the community was to get them to support decriminalizing drugs. The community wanted to decriminalize Black life. So in a world where we decriminalize cannabis, they were seeing things like, not only do you put street entrepreneurs out of business, and people were saying this, and it's actually empirically proven in California, it's actually more of an incentive to police street sales of cannabis after you legalize cannabis. Because now you're competing with the legal market, and you're competing with the state, because they don't make tax sales on street cannabis sales. So people didn't want to just decriminalize drugs. They wanted economic development, police reform, and violence prevention as a corollary to the criminalization of drugs, because their concern was that with the experience of the crack epidemic, they saw drug policy liberalization with an increased possibility of street violence occurring. And all of the assurances of advocates that decriminalization does not lead to more drug sales and not lead to more violence wasn't sufficient to address people's concerns that were consistent. They wanted investments in community-based violence prevention, the type of folks that go into community, know folks who carry guns, mediate conflict, and can squash those beasts before they lead to violence. And that work with University of Maryland extends into our independent research as LBS, as advocates and researchers on violence prevention. So we developed an independent research product called Fear of a Black Planet, which is a compilation of our experiences of criminal justice reform and our work around violence prevention. And it allowed us to interrogate some, again, of the methodological limitations of traditional research methodologies around violence prevention. For one example of this, there was a paper that recently, quote unquote, validated community-based public health approaches to violence prevention in Baltimore. It was a very big deal. This is people who are oftentimes formerly in street organizations, so-called gang members, mediating conflicts in the streets. They're under attack from conservative media, Sinclair Media, Fox News. They're based in Baltimore, so they're continuously attacking this program, saying you're basically paying thugs to be thugs. And it was a big deal to say this works. However, in my experience, this particular program existed in a universe of programming, and tying the decline in violence into the communities this program operated obscured the impact of the grassroots community-based programs that operate alongside this program in these very same communities. So after a mass shooting, a horrible mass shooting in Baltimore in 2023, I was in the meeting, and one of the people who's most affiliated with this grassroots violence prevention program said, we're going to be under 300 murders this year. I know it, because I talked to people. He didn't need, a regression to understand the trajectory of the work that was going on, because this person had been doing work in community for a decade. Sure enough, in Baltimore in 2023, we're under, I believe, around 250 murders for the year. So while we are excited to validate traditional public health approaches to violence prevention, the power dynamics come in when you associate violence declines primarily or only to those tied to the public health establishment, to those tied to dominant universities, to those given the money to do programmatic evaluations. Because what happens is that the grassroots programs that actually have been essential to producing the violence decline get framed out of the story. And then you try to replicate the program without the grassroots organizations, and it doesn't work. So not only have you obscured the importance of grassroots programs, you've created false models for replication. And in fact, we're seeing that these public health violence intervention programs work best in communities that have substantial public grassroots buy-in. And that's very hard to replicate and to scale up inorganically. You must kind of come from the bottom up with that. Additionally, going back to politics, what I'm seeing in the violence prevention space is that capital P, political theory, is guiding research. And it's understandable because people are desperate for money. It's a desperate problem to solve. But there's a theory about violence prevention that says, look, 4-year term. So your violence prevention program has to plan impacting year 3. And the way to do that is you have to combine the violence prevention work with policing, because you need the so-called incapacitation effect of so-called targeted deterrence enforcement in these communities. Now, in our research, not only does not violate what community sees what they wanted violence prevention to do, which is being alternative to funding police, when you have so-called targeted enforcement, you oftentimes increase incarceration rates, which can increase community instability, which can lead folks to come out of jail even more hardened and increase crime in the future, but after your 3-year window when you stop doing your research. So you've intentionally framed out the impact when those folks come out of jail. You've excluded that from your research catchment area. And the actual empirically proven potential to increase crime, you don't have to worry about that, because you've done what you need to do, is give a politician a 3-year plan to get violence declines before the next election. So again, it's important to understand that as much as we engage federal research cycles, and as much as we have opportunities for research money, there's real politics at play that's impacting our research. And finally, before I get to my conclusion, I want to state that it's impacting our research methodologies that we perceive as desirable. So with the desire for quote-unquote evidence-based methodology, much of the violence prevention field is calling that work cognitive behavioral therapy. They're sort of taking these cognitive behavioral approaches, and this public health view of violence leads to medicalized interventions that oftentimes view violent impulses as cognitive distortions that need to be essentially dealt with through training, meditation, medication, things like that. This is understandable, but from a community-based perspective, it's very frightening, because from our perspective, there's a fine line between the anger that gets externalized into community-based violence and the righteous indignation over systems of oppression that we face every day. And pathologizing anger, pathologizing that righteous indignation, and asking us to have quote-unquote positive attachments to mainstream institutions, which is what the literature actually says, begs the question of whether those institutions deserve to be attached to in the first place. What is the systemic change? What is the systemic work that needs to be done to make those institutions worth attaching to? You know, public violence as a disease. So I somewhat jokingly, but not really jokingly, say if violence is a disease in the Black community, who's patient 0? Who's the typhoid Mary? And I somewhat facetiously, but not facetiously, based upon the work of our elders in this space, given the answer of Christopher Columbus. So when you have that framework for violence prevention, that is an extension of a Black grassroots, Black radical methodology that says that we've been injected with the disease of violence. It's not organic to us. And by framing out the systemic injection of that oppression, you risk having people believe not that violence is diseased in our community, but our communities are diseased. And therefore, we need someone outside of our community to come and heal us. And so these are the very real stakes, because the methodologies you choose when you see oppositional defiance, it's not a cognitive behavioral distortion, but a positive expression of oppressed people's desire for freedom. You redirect that oppositional defiance into positive pro-social political engagement to protect community. And that's been not only the violence prevention methodology, but also an addiction methodology that has been used effectively in the Black community for decades. Florida State University Professor Naeem Akbar talks about this when he says, the Black community had a spiritual, organic methodology that turned a pimp, a hustler called Detroit Red into Malcolm X, an instrument of liberation for people all over the world. What other psychologist can brag about doing something like that? He says, come on, Freud, come on, Maslow, name me one person that you've taken from an instrument of destruction to an instrument of liberation, the way Detroit did, the way the Black community did with Detroit Red turning him to Malcolm. But the problem is those methodologies aren't easily fundable. They aren't easily researched, they aren't easily quantified, they aren't easily written into many federal grants. So that leads me to my conclusions. We have to work with developing relationships between community and intentionally engage in the political economy of research. So again, the goal is we need community to be engaged, and the Black radical tradition says that we can use federal grant money and other grant monies to invest in exposing and fleshing out the organic work being done in community. But the incentives are to do the opposite, is to create a methodology you know is fundable and bring community along with you. So it's important that we're willing to take this battle on. We're actually going to do a webinar in October around the politics around violence prevention, this new federal government push tied to the Democratic Party's desires to assuage concerns about crime. But what does that do to the way that they write their RFPs for what they view as best practice for funding? How do we engage the real need for money and the real political danger of potentially pathologizing community? So we're going to do the work to negotiate that. We hope folks can come along with us. We think that examples like the University of Maryland at Baltimore's work with the Violence Prevention Center, I think they've committed to trying to do work expanding the capacity of and evaluating Black grassroots violence prevention methodologies in this tradition. And I think those are the examples of work we have to support. And lastly, I would say it's important to invest in community-based research generation, because so often we get called in when people need something. We get called in when people need credibility. We get called in when people need, so-called Black stamp. And honestly, a lot of those folks benefit more from those relationships than we do, even when we're paid, right? So we do fee-for-service research, and that money is important because we don't get paid to advocate on issues we advocate for. Our model tells us that we're going to make the money doing these fee-for-service contracts so we can advocate for whatever we want. But money itself is not going to be the solution to the problem. So definitely give money to your Black grassroots organizations, but in a larger reality, we need people to understand what I've been trying to get through in this talk, that it's not about seeing the morality in investing in us. It's a matter of solving the problem. And right now, traditional academics miss losing vital insights about how to solve the problems that they are researching because of this divide. And we say sometimes that the standard for what passes for proficiency when engaging the problems of the Black community is not something we'd accept for most other issues. So we've done research on African traditional healers. We've done research on the history of work in the Black community during slavery, during Reconstruction, before the Northern Migration, after the Northern Migration. This is the type of work it's going to take for researchers to gain the fluency in the actual cultural expertise Black folks have to allow the folks in traditional academia to be effective allies for the work that we do. So the goal is to be willing to reach out to people, because there may not be an LBS in every city, but reach out to folks you know are doing work, listen, engage. That doesn't cost you anything, all right? So we hope that, I hope that this was useful, and I look forward to the Q&A. Thank you.
Thank you so much to our three speakers. As mentioned, we will be having a full Q&A after the coffee break, and so we will wrap things up now for folks to be able to able to ask individual questions or attend the coffee break, and then we'll be in the Columbia foyer, which is if you exit, right out the doors, it's to the right. And so please join us there at 10. Thank you all so much for being here, but thank you so much to our three speakers who gave us just incredible perspectives. I feel like I've been on an entire journey this morning, and I'm really looking forward to discussing further. Thank you all so much.